In this session, we are going to be looking at the topic TIPS, which expands to Transjugular Intrahepatic Portosystemic Shunt. Hi, I'm Sharon. I'm working as an assistant professor at College of Nursing. The following are the objectives that we'll be addressing in this session. The Transjugular Intrahepatic Portosystemic Shunt (TIPS) was developed for treatment of complications of portal hypertension, which is a major complication of cirrhosis. It results from increased intrahepatic resistance and increased splanchnic blood flow leading to a hyperdynamic circulatory state. It is a radiological intervention. It is a side-to-side portocaval shunt that connects the portal and hepatic veins within the hepatic parenchyma. The first implantation was done in 1988. The indications of TIPS are divided into two, main and rare. In main, variceal bleeding. Varices are dilated submucosal veins most commonly detected in the distal esophagus or proximal stomach. They are associated with portal hypertension of any cause, including pre-sinusoidal, that is in portal vein thrombosis, sinusoidal in cirrhosis, and post-sinusoidal Budd-Chiari syndrome, causes the commonest being cirrhosis. So here they try to manage acute bleeding as a matter of prophylaxis, variceal embolization, and prevention of rebleeding. The next indication is refractive ascites. In that, we have hepatorenal syndrome. It is the development of renal failure in patients with advanced chronic liver disease and occasionally fulminant hepatitis in those who have portal hypertension and ascites. The next is hepatic hydrothorax. This refers to the presence of pleural effusion, usually more than 500 ml, in a patient with cirrhosis who does not have other reasons to have a pleural effusion, and closure of umbilical hernia. In the rare indications, we have portal vein thrombosis, palliation in malignancies, liver transplantation, lower GI bleeding, Budd-Chiari syndrome, which is a rare disorder characterized by narrowing and obstruction of the hepatic veins, and finally, veno-occlusive disease. The contraindications for TIPS include two again, relative and absolute. The relative contraindications being hepatocellular carcinoma, especially centrally located, obstruction of all hepatic veins, portal vein thrombosis, moderate pulmonary hypertension, severe coagulopathy, where the international normalized ratio is more than 5, thrombocytopenia of less than 20,000 cells per centimeter cube, and hepatic encephalopathy. In absolute, we have primary prevention of variceal bleeding, congestive heart failure, severe tricuspid regurgitation, severe pulmonary hypertension, multiple hepatic cysts, uncontrolled systemic infection or sepsis, and unrelieved biliary obstruction. The procedure is initiated with the introduction of a long curved needle from the right internal jugular vein into the hepatic vein. The needle is advanced through the liver parenchyma into a branch of the portal vein. The resultant hepatic to portal vein tract is catheterized and dilated. An expandable metallic stent is deployed across the tract to support the shunt channel. Portal venography is then performed to assess the extent of portal decompression. If residual varices are identified, the shunt is dilated with a larger balloon and/or the residual varices are embolized with coils. Role of nurse in pre-procedure care to provide psychological and emotional support, ensure that the written consent is obtained. Continuous and effective monitoring for clinical signs of hemodynamic compromise must be maintained at all times. Administer tranquilizers such as diazepam and midazolam or even narcotic analgesics as per order. Administration of antibiotics prior to procedure if necessary. Care during procedure. Monitor the patient's vital signs and his or her level of consciousness. Supporting the radiologist by providing him or her with the materials and equipment required during the stent placement while following strict aseptic precautions. In post-procedure care, monitoring the patient's vital signs and his or her level of consciousness, watching out for complications, educate on diet, signs and symptoms of hepatic encephalopathy. Let's look at the individual risk for complications. Gender, age, pre-existing encephalopathy, elevated liver enzymes, hyperbilirubinemia, high creatinine, low albumin level, presence of ascites, and emergent versus elective TIPS procedure. Elective being more safer. In general, it has been described that patients undergoing emergent TIPS, a child PUG score more than 12, it assesses cirrhosis mortality and estimates the severity of cirrhosis. A prognostic index score of more than 18.52 or an acute physiology and chronic health evaluation, Apache 2 score more than 18 have a poor prognosis. Recently, the model of end-stage liver disease, MELD score, was developed to predict the 3-month mortality of patients undergoing elective TIPS. In this scoring system, the serum bilirubin levels, the serum creatinine levels, and international normalized ratio are plotted in a formula and a score is calculated. A MELD score greater than 18 has been described to be associated with a poor prognosis. The following are the complications for TIPS procedure: rebleeding, direct procedural mortality, 30-day mortality, procedural morbidity, encephalopathy, radiation injuries. Related to transhepatic needle puncture, there can be transcapsular puncture, biliary duct puncture, hepatic artery puncture, gallbladder puncture, and right kidney puncture. Related to the transvenous access to the portal vein, there can be cardiac arrhythmias, right atrial puncture, inferior vena cava puncture. Related to cannulation or dilation of the portal vein, there can be portal venous rupture, splenoportal venous thrombosis, and capsular laceration. Related to the stent, acute stent thrombosis, delayed shunt occlusion, delayed shunt stenosis of the stent or the hepatic vein, stent shortening or incomplete placement, stent extension or protrusion into the inferior vena cava, stent separation or dislodgement or migration, stent-induced hemolysis, stent recoil. Related to the puncture site, there can be hematoma or bleeding, inadvertent carotid artery puncture, inadvertent tracheal puncture. Related to portosystemic shunting, new or worsened hepatic encephalopathy, fever or sepsis, deterioration of liver function, myocardial infarction, and generalized coagulopathy. Related to contrast material, allergic reaction, nephrotoxicity, or acute renal failure can occur. The following are the references. Thank you for your patient listening.